Good morning, everyone. Welcome to the 2018 Canada Gairdner Global Health Symposium. My name is Stanley Zlotkin. I'm the Chief of Global Child Health here at the Hospital for Sick Children. I'd like to first thank the sponsors for today's, what is likely to be a fabulous symposium. Thank the Gairdner Foundation. I'd like to thank the Dalla School of Public Health at the University of Toronto and Grand Challenges Canada for their support of this symposium. I'd like to welcome, of course, our distinguished speakers, Dr. Chris Murray and Dr. Alan Lopez, who are the 2018 John Dirks Canada Gairdner Global Health Laureates, and Janet Rossant is going to introduce them in a moment. I'd also like to welcome our esteemed group of panelists, whom I will introduce after the coffee break. It is my pleasure to introduce my friend and colleague, Janet Rossant. Janet, where are you? Oh, there you are. Janet Rossant. Janet is the president and scientific director of the Gairdner Foundation. What you don't know about Janet is that she built this incredible edifice that you're sitting in now, the Peter Gilligan Center for Learning and Research and Learning. She didn't build it with her own hands, but she certainly built it with her blood, sweat, and her tears as she was the Director of Research for the Hospital for Sick Children. Janet is now the Chief of Research Emeritus at the Hospital for Sick Children. She's a senior scientist in the Developmental and Stem Cell Biology program. She's the Lombard Insurance Chair in Pediatric Research, and she's a professor in the Department of Molecular Genetics, Obstetrics, and Gynecology at the University of Toronto. And Janet, it is your lovely task to introduce our keynote speakers.
Thank you, Stan. And it really is a pleasure to be, obviously, here where I belong in PGCRL, but also from the point of view of the Gairdner Foundation, to be partnering again with SickKids to have a global health symposium. So thanks, Stan and the Centre for Global Health with partnering for us, and also the Dalla School of Public Health. So today's symposium and workshop is really built around the presence here today of the winners of the 2018 John Dirks Canada Gairdner Global Health Award. And this prize was the vision of our previous president of the foundation, Dr. John Dirks. And so when he retired, it was a kind of easy change to name the award after him. So it is named in his honor, and he's here with us today. So I'd like to welcome Dr. John Dirks to enjoy the fruits of his concept. And indeed, the Global Health Award recognizes the world's top scientists who've made outstanding achievements in global health research. And since its inception, this award has grown rapidly to become one of the world's most prestigious awards recognizing excellence in global health research. And I'll just tell you, because you're all sitting there, you should think about potentially people who could be nominated for this award in the future. Nominees are individuals who've made major scientific advances with significant impact on health outcomes in the developing world. And nominations are closed for this year. We're in the middle of sorting through them, but I encourage anyone, because nominations are open, to think about nominating a deserving global health research leader via our website next year. And we're especially encouraging nominations from groups who are underrepresented in our awards program, especially women, and in this case, particularly, we're looking for more nominations of people who are actually working in the developing world. So please think about it and think about the kind of scientists you would like to hear next year. So for the first time, actually, this award is recognizing two scientists because it's not possible to split them. Lopez and Murray go together. Dr. Alan Lopez is Melbourne Laureate Professor, Rowden White Chair of Global Health and Burden of Disease Measurement at the University of Melbourne in Australia. And Dr. Christopher Murray is Director of the Institute for Health Metrics and Evaluation and Chair of the Department of Health Metric Sciences in the School of Medicine at the University of Washington in Seattle. And they are co-founders of the Global Burden of Disease Study, which is a systematic scientific effort to quantify the comparative magnitude of health loss from all major diseases, injuries, and risk factors by age, sex, and location over time and over the world. And over the last 2 decades, their study's grown to cover more, as you'll hear, more than 300 diseases and injuries in nearly 200 countries from 1990 to the present. And what this does is really to allow you amazing comparisons across time, over age groups, and across populations. And of course, the idea behind this is to develop data that can influence policy and lead to improvements in health systems and health, overall health, in countries around the world. And so I certainly have enjoyed learning about their work through the nomination process, through meeting them, and through hearing their talks as we start to develop receptions, other lectures across the country. And I'm sure you're going to really enjoy their presentation this morning. So please join me in welcoming 2018 John Dirks Canada Gairdner Global Health Award laureates to the stage. And I think Alan is going first.
Thank you very much, Janet and Stan, and good morning, ladies and gentlemen. It's obviously an enormous pleasure and an honour to be here at this symposium today. Normally, the partnership you see over the last 30 years is Murray and Lopez. We've decided to reverse the order, and Lopez and Murray, that way I get more of the time, but I'm not sure that will work. The symposium is titled, What are the Big Challenges to Improving Global Health? Insights from the Global Burden of Disease Study. And what we'd like to do today is to provide an overview along those lines. So many of you will be familiar with the Global Burden of Disease Study, some of you won't. So I'll start by giving a definition of the Global Burden of Disease Study, a brief description. We'll then talk a little bit about the evolution of the GBD study from its origins in the early 1990s until today. A little bit about the complexity that the study has seen, the partnerships and other dimensions of evolution that I think are important for us to learn from in terms of the GBD journey. Chris will then talk about some of the findings, the key findings. There are many, but we will try and distill those out to the most important implications for the theme of this symposium in terms of improving global health. What really matters in terms of improving global health, and how does this health accounting framework, which is essentially what the global burden of disease is, specify those priorities. And then Chris will talk a little bit about what we call GBD extensions. Such a study as the GBD is not just a framework for global health accounting. It has many, many uses in terms of generating the evidence base for health development today. Many of the initiatives, the global initiatives, require information about health loss in populations, what causes that and how it's changing. And some of those are, of course, Sustainable Development Goals monitoring, but also the big epidemics of our time, the ones that are still there, that haven't gone away, the fact that 5 million children still die each year, things like obesity, which is now becoming more and more prominent, as well as tobacco. And so Chris will provide some insights into how the GBD as a framework addresses those big global challenges. So the why of the GBD, Janet actually introduced very nicely. What is required in global health is some platform of health accounting, something that takes data and information and creates evidence about the key health causes of health loss in populations and how those causes are changing. So I think we'll all agree, sitting here, that while evidence is not enough on its own to shape health policies and health priorities, it is an essential input into any public discourse about key health priorities, no matter where we are on the planet. And so the global burden of disease tries to fill that void. What is it? As Janet introduced, we like to think of it in terms of a systematic scientific endeavour to produce or quantify the comparative magnitude, very, very important, the comparative magnitude of health loss. We measure health loss, either death or disability, in a comparative fashion as best we can, so that ministers of health or health communities everywhere on the planet can compare health loss from measles, malaria, TB, road traffic accidents, ischemic heart disease, as well as risk factors like alcohol, tobacco, obesity, unsafe sex, and so on, in a comparative framework. Because this is what ministers need to have in terms of evidence about health priorities. We don't just do it for a handful of diseases. What I haven't added here on this slide is comprehensive. The global burden of disease set out to be comprehensive, it's become even more so. It quantifies health loss from almost 200, in about 200 countries and territories, and increasingly we are doing that at the subnational level. It doesn't make a lot of sense to talk about burden of disease in China or India, given the large populations there. So we are progressively disaggregating those units of analysis. We do it for almost 360 diseases and injuries, so that everything that we think is of public health importance, of global health importance and priority, is quantified in terms of its health loss in different countries and how it's changing. And equally, we don't just talk about mortality, we talk about health loss from non-fatal outcomes. Societies spend a lot of money in keeping people healthy, not just keeping people alive, and we need to quantify health loss from disability. We do 84 risk factors as well. So it's not just alcohol, tobacco, and your top 10 favourites. We do 84 causes of health loss in populations. We do it every year from 1990 to the present. And every time we make a new burden of disease study, we go back and re-estimate the entire time series so that there's no methodological biases. And finally, the publications of the global burden of disease you're probably familiar with. They come out in various fora, scientific journals, particularly The Lancet, but not only. And more importantly, perhaps, the data visualizations that are hosted by the IHME website, which Chris, I'm sure, will talk about in a moment. I won't show any algebra on methods, but this is a summary slide on the methods of the GBD, and we should start on the left-hand side by the key challenges. You can imagine when you're trying to quantify so many diseases and injuries in so many populations, you're not going to have a lot of consistent data for many of those entities. And indeed, inconsistent coding, inconsistent case definitions. What is an LRI in one population or one data set may not be defined the same way in another one. In many populations, there's no data. How do we know about lung cancer in Mali? There is no data. So what do? We can't create a global burden of disease study without lung cancer in Mali. So we'll need to address that. Conflicting data. Data sources are collected in different ways. There's often, for the same quantity of interest, we'll find quite different estimates from the data that's available to us. Data are characterized by both sampling, but equally importantly, non-sampling error in the various data sources that are available to us. We need to figure out a way to address that. And then there's excluded groups. The data are often present perhaps just for urban areas or for some parts of the population or some sectors of the population. Others are excluded, not just rural and remote communities, but often there's systematic exclusions of other population subgroups. We need to figure out how to measure what might be happening in those groups as well. What are the solutions that we do? What is the sort of the basis of our methodology? Firstly, there's a quality review of every single data source that we use in the GBD. And there's about 100,000 of them, as I'll show in a moment. So every one of those data sources is put through a strict data audit so that we can try to correct for systematic biases in the data. The most obvious one, the one that we've done over the years, is what we call garbage coding, where physicians in many countries assign the underlying cause of death not to a specific condition like ischemic heart disease or chronic bronchitis, but they'll say, I don't know, ill-defined, or heart failure, or septicemia, something vague like that, that cannot be an underlying cause of death. So we need to correct that. We also need to figure out methods to crosswalk between the various data sources that we have. Just because the diagnostic methods, the definitions of various data sources are often very different, although they're essentially measuring the same quantity of interest. And we have to figure out ways in which we can make those data sources talk to each other about a common entity. And then we use statistical methods to deal with missing data, data imputation methods, inconsistent data, the way that we resolve data using statistical methods, excluded groups, and also taking into account measurement error in the various data sources. These are well described in our publications. I won't go into them, but I just wanted to summarize the sort of three key things that we do methodologically. And what we do, the outcomes of the GBD, and by the way, for every single cycle of the global burden of disease, there are 24 billion estimates. Now, I'm not going to talk about 24 billion estimates today, but we summarize those estimates in a few standard outcome measures. The ones you're familiar with: incidence, prevalence, case fatality, death rates, death numbers. The common ones are all there. But more importantly, years ago, when we first did the burden of disease study, we needed to figure out a way to unite health loss from disability with health loss from premature mortality. How do you do that? And so we did that by streaming these health losses out into the future for premature mortality, the years of life lost, building on concepts developed by Mary Dempsey and others in the 1940s, and then years of life lived with disability, which we now define as the prevalence of a disability, a health loss state, multiplied by a disability weight on a scale of 0 to 1. We add those two together. So those years of life lost in the future, those years of life lived with disability in the future, added together to form DALYs, or disability adjusted life years. And that's our measure, our primary measure of health loss. We also calculate health-adjusted life expectancy, or HALE, but I'll talk primarily about DALYs. The publications where you can find them, here's the last two cycles of the GBD, published in The Lancet, usually in September, October every year. They're typically 400 pages, so they're not necessarily light reading, but they're essential reading for people interested in global health. And these are the GBD 2015 study, published in 2016. The last one published 2016 last year, and the GBD 2017 will be issued, I think, in 2 weeks' time in The Lancet in November. So that is a very quick definition, an overview of what is the GBD. I think it's very important now to see where this has come from. Where did we start? What are Chris and I being acknowledged for in the Gairdner Awards, and where we've come to today, and why we've come on that journey. So the origins of the GBD, going back to the late 1980s, when I was at WHO, I used to walk around to the programs there and ask, what are the leading causes of child death? And I'll add them all up together, and we found that we were killing children about 3 times over. So the programs in WHO, they were fantastic advocates, but they were poor epidemiologists. And so when Chris and I were confronted with this problem, we found that there was no consistent, comprehensive measurement of child health, either child health or adult health, indeed, life expectancy generally. So no consistent way of counting deaths worldwide. So the World Development Report, 1993, the one that's shown up there in red, was the origin of the Global Burden of Disease study. Dean Jamison and Larry Summers at the bank, who were leading that, asked Chris, and Chris asked me to join him to quantify the global burden of disease for the World Development Report, 1993, primarily for the folks at the World Bank, the health economists, to develop packages of cost-effective interventions against the key causes of health loss in different regions of the world. The preliminary results of the first GBD study were published in that document, which was largely a political document read by ministers of finance, which was very important, but it didn't have a lot of scientific detail. And so that was published in those 2 books underneath. You see there the 2 books, each of about 1,000 pages, that Chris and I put together on the initial methods of the Global Burden of Disease study. They were published in 1996, and importantly, a Lancet quartet of papers that a new editor of the Lancet, Richard Horton, thought this was important and gave us 4 papers, which we published in 1997. Those were the origins of the GBD. It has evolved substantially over the last quarter of a century, and I'll quickly go through 6 or 7 of those key evolutions. Firstly, from this table from the Lancet, you can see yourself just how complex and detailed and granular the Global Burden of Disease study has become. We haven't done that because we thought it was a scientific necessity. We've done that because the public health community have asked for more and more detail about diseases, about locations, about time. And so from 1990, when our first study was 107 diseases and injuries, it's now, as you saw, 359, and in 2016 was 333. Look at the growth in risk factors, an 8-fold increase in the volume of risk factors that we quantify, a 7-fold increase in the number of non-fatal sequelae that we measure in the Global Burden of Disease. The number of geographies has gone from 8 World Bank regions to 774 24 separate countries and sub-regions of countries in the last round. And in 2017, that's close to 1,000. So this is growing very rapidly into a very detailed and complex study. Initially, the GBD study we did for 1 year, 1990. We now do it for every single year, as I mentioned, every time that we do it. And you can just see the summary there. In the GBD 1990 was about 10,000 condition, age, sex, location, year estimates. The GBD 2016 was 400 million, or 43,000 times more detail than our initial study. We don't do all this alone. The initial study was Murray and Lopez in a barn in Maine with 6 or 7 very, very dedicated RAs from Harvard doing the global burden of disease study. It's clearly impossible. It's not a great methodology to replicate. We now have a vast global collaboration of 3,600 collaborators from almost 150 countries who work on it. And you can see the density of collaborators there. The United States, Australia, Brazil, India, Iran, Ethiopia, South Africa, countries where we've got more than 100 collaborators each, Canada 50 to 100, probably closer to 100. So several of you in this audience may well be part of our global collaboration, and we're absolutely delighted by that. We started off pretty rudimentary with spreadsheets. I know you'll laugh at that. It's become a lot more complicated since then. We also have developed important oversight mechanisms. The initial study was essentially Chris and I, and then our peers were reviewing and giving us advice, saying that can't be right or that looks absurd, go back and have another look at it. These days we have a scientific council from representatives from all over the world who critique what we do, who offer advice about extensions of the GBD, and we have an independent advisory committee for the GBD who are very engaged about the quality and directions and impact of the work. Another dimension that we've taken is from what we call plausible estimates to full statistical theory. Chris and I realised when we were first doing the study that it was going to be very, very difficult to be right, given the challenges of quantifying disease burden for the first time ever, but also the lack of data. So we aimed to be plausible. We tried to avoid the laugh factor. Does this look about right, given our knowledge of TB or lung cancer or tobacco and so on in the world? So we made point estimates for each quantity of interest that preserved epidemiological consistency between incidence, prevalence, case fatality, and mortality. And we built a tool called DISMOD1, which was essentially a way to ensure that epidemiological consistency anchored on the parameter value, prevalence or incidence or mortality, that we had the most confidence in. And we built the entire epidemiological history of that condition around DISMOD1. From 2010, the GBD 2010 onwards, we moved to a much more sophisticated statistical environment using Bayesian statistical models. And now we calculate uncertainty intervals around every single estimate in the GBD. And that's very important because we should not be conveying to policymakers how much we do know. We need to be equally conveying to policymakers how much we don't know, and that the improvement of health information systems in countries to better measure burden of disease is an absolute public health priority. A fourth dimension of evolution is the increased transparency of the outcomes. Chris and I published 2 books, or actually 4 books, the first 2 of which you saw there, several papers, but we never really published the primary data or the spreadsheets that we used to calculate that initial burden of disease, for reasons that are probably obvious to you and I won't go into. But subsequently, public debate about strengthening global health metrics has led to the development of the GATHER guidelines, and we've made sure that every single GBD study now is absolutely consistent with those GATHER guidelines in terms of making information available about data sources. And I've just had a screenshot there of the GBDX website, and there's 100,000 data sources there where there's metadata about each of those data sources in the GBD to show it's possible for everyone to have a look at that and see the nature of the data sources that we are using. And that increased transparency is just part of a global movement in epidemiology and global health to do that. There are new ways to share information, and Chris again may pick this up towards the end of his talk. This is on the IHME website. There's the URL there. I urge you all to, if you haven't, to go on and have a look. It is the most amazing visualization of public health results that I've ever seen. It allows you to take whatever location, the world, Canada, whatever group of location of the GBD we've done, and explore whatever you want about health loss in that population. So this particular graph here, now it's in Norwegian for the Norwegian speakers, but it does exist in English, French, Spanish, Chinese and Portuguese, and it shows, this particular graph shows a snapshot of the comparative importance of DALYs from non-communicable diseases in blue, from infectious and communicable diseases and maternal and neonatal in red, and from injuries in green. And then particular conditions within each of those categories, and they get bigger and smaller as you go along in time. So this is called, this particular graph is called GBD Compare, but if you look down at the left-hand side, you'll see a number of icons, and those icons allow you to look at data in different ways, either as these what we call tree maps, as this one is, or as rankings, or as arrow diagrams, things going up and down, all sorts of ways to look at the way that data on burden of disease in particular locations over time from particular conditions is changing. And that has helped dramatically increase the dissemination of GBD results because it's very easy to, and very, very engaging to look at. The sixth dimension of evolution is a much expanded scope of the GBD. The original study was just to quantify the burden of disease in 1990, essentially. We also actually projected the GBD to 2020, but it was primarily around 1990. It's moved well beyond then. So, for example, the whole GBD framework and platform is now used to calculate expected burden of disease in populations as opposed to observed burden of disease. So we can quantify burden of disease, as Chris will show in a moment, based on socio-demographic indicators. And then we can compare what we observe in that population with what we expect and see whether a country or a population is doing better or worse. We can monitor sustainable development goals. This is really important. Those of you who followed the MDGs, you'll see that the final part of the MDGs, the final few years, there was an acceleration in health gain because the MDGs had that sort of impact. We hope the SDGs will do the same. Universal health coverage, healthcare access, we measure new dimensions of health care and quality. Also, more recently, just recently, we've published a measurement of human capital in collaboration with the World Bank, most of these in the Lancet. And finally, just moving from an episodic approach where the GBD was done in 1990, it was done again when we were at WHO in the late 1990s, done again in 2010. It's now done much more systematically. In fact, it's done annual estimates. This has a number of positive impacts, we think, encouraging innovation in methods and data collection, greatly increasing the relevance of the GBD as a tool for monitoring. If it's done annually, that's clearly the case. And it focuses public policy attention not on the levels of health loss in populations, but on the rates of change of those health loss, which is something you can only do by doing annual episodes. So that's a brief overview of what it is and where it's come from, and Chris will now tell us some of the results that we found.
Thanks, Alan. And what I'll do is dive into some of the findings. I'm going to use a smattering of unpublished results that will be out in 2 weeks from GBD 2017 and some from GBD 2016. So this is a diagram of deaths in the world from 1950 to 2017 by age. And the neonatal period is in the red colors, 1 to 4 is in the slightly orange color, through to deaths 95 plus in the dark purple colors. And one of the major defining transformations of the last 70 years is the enormous reduction both in the number of child deaths as well as the reduction in the share of deaths that are in children, as two things have been going on, namely faster decline in child death rates than in the death rates in younger adults and older adults, and due to fertility change, a shift in the world's population towards older age groups. The big spike in the 60s, of course, is the Great Leap Forward in China, where there was an excess of about 20 million deaths due to the Great Famine. And you can see other sort of cataclysmic events, such as the Rwandan genocide and the Haiti earthquake, create some of the year-to-year fluctuation that you see in death numbers. Another thing that we do in the GBD is because we have this very long-running view, and as Alan mentioned, we're trying to increasingly provide people trying to interpret the data with useful heuristics. We have tried to describe the epidemiological transition, and here's one example of that. We have a measure of development, which is based on income per capita, years of schooling, and the fertility rate, as a general measure of development on the x-axis. And on the y-axis is life expectancy. And every country in every year back to 1970 is a point. So there's a lot of points on this graph. And they're also colored by decade. Red is in the 70s through to blue in the last 7 years. And what you can see is the average relationship between development and life expectancy, which is very, very strong. This is for women. And you can also see that in addition to that very strong average relationship, there's about a 10-year variation in life expectancy at any given level of development. So there's huge scope at the same level of development to have better outcomes. And you can also see temporal patterns here where if you look particularly at high levels of development, there's a clear gradient where the red color is mostly below the black line and the blue color is mostly above the black line. Not true at low and middle levels of development. But so we're seeing this sort of technology shift at the highest levels of development, and largely development itself is the main driver at lower levels. Here's sort of everything you need to know about causes of death in one diagram. And this divides countries based on their 2016 status into quintiles of development. Lowest on the left, highest on the right. And these are age-standardized rates of years of life lost for the three big cause groups in the GBD. The communicable, maternal, neonatal, nutritional causes that tend to be highly correlated with each other in red, the non-communicable causes in blue, and injuries in green. And in every single one, you can see there's a temporal decline in each of the 5 quintiles in the communicable, maternal, neonatal, and nutritional causes in the age-standardized rates. But there's also a decline in pretty much all of the quintiles over time in NCD rates of premature death. So the epidemic of NCDs is not because age-standardized rates are going up. This is one of the great fallacies in global health, where people think the epidemic of NCDs is because those rates are going up because of income elastic metabolic risk factors and other things associated with development. Not true. We'll see where the epidemic is in the next slide, but also notice on the green, you can see some of the large events in the past, the genocide in Rwanda, the Haiti earthquake, and others. So not only is there this temporal decline in the communicable, maternal, neonatal, nutritional causes and NCDs, but there's also this very clear gradient across the different quintiles, as you can see in the diagram. Much less of a gradient across the quintiles for NCDs than there is for the communicable, maternal, and neonatal. Now, if I shift to numbers, now we see the epidemic of NCDs, which is the numbers of years of life lost due to NCDs in the bottom 3 quintiles are going up quite substantially, and the number of years of life lost in the top 2 quintiles are constant for NCDs, and that's driven by population growth and largely aging. So the key driver of the shift to NCDs is faster rates of decline in the rates for the communicable, maternal, and neonatal, despite setbacks like the HIV epidemic, and this relatively slow declines in the rest combined with population growth and aging, and you get a mixed pattern for injuries, as you can see in the diagram. The same information for the non-fatal components of the burden is shown here. And there's some things to notice here. First of all, the age standardized rates at the top are basically flat for NCD burden. Most of the non-fatal burden everywhere in the lowest quintile to the top is actually from NCDs, not from the communicable maternal and neonatal causes. And the reason for that flat line is that the biggest causes of non-fatal burden are mental health, mental disorders, substance abuse, and musculoskeletal disorders, and to some extent neurological disorders. And there's no trend globally in the age standardized rates for those conditions. So age standardized rates for those have held pretty constant as far as we know from the available data. And the burden from communicable maternal and neonatal is going down, as it was for mortality, but slower. So we've had more progress on mortality than we've had for disease prevalence, partly reflecting the benefits of treatment and less effect on the drivers of disease incidence or prevalence. And then on the bottom sequence, you can see the same phenomenon due to population growth and aging, the explosion of numbers of people implied by the YLDs with non-communicable causes. And the bottom panel is the reality for health systems, that those are actually what health systems represents, the numbers of people and the burden that health systems actually have to deal with. Now, if we want to drill into a little bit more detail, here is the rank order in 2005. And in the online tools, as Alan mentioned, you can play with any year or any ordering that you're interested in. But this is the rank order at level 2 of the GBD cause hierarchy. So the GBD is a hierarchical cause structure. So we start with 3 broad groups, and then for level 2, we have 21 cause groups. And then as you go deeper into the cause list, you get to more specific diseases. At each level of the cause list, it's mutually exclusive and collectively exhaustive. So everything's present at each level. So this is level 2. The rank in 2005 globally for DALYs, the rank in 2016 globally on the right-hand side. And you can see some of the big shifts. You know, HIV, AIDS, and TB, big drop at level 2 from 2005 to present. You can see cardiovascular diseases going to the top. Mental disorders is number 6, musculoskeletal disorders number 7, and unintentional injuries number 9. If we go to more specific causes for the top 10, here's where you see IHD and stroke at the top, still pneumonia at number 3. You start to see one of the musculoskeletal disorders that's highly prevalent and some substantial fraction of individuals severely afflicted, namely low back and neck pain at number 4, diarrhea at number 5, road injury at 6, and then deafness and blindness and visual and hearing impairment at number 7, COPD at number 8, and neonatal preterm birth at number 9. Huge transitions, the crossing lines, and if you zoom out a little bit more, it's harder to see in an audience on a screen like this. If we were to show you the top 30 or 40, there's tremendous volume of change in the world, with a number of causes dropping over the last 25 years really quite profoundly. Take measles, for example, due to immunization, being a top 20 cause in 1990, and now I think is 66th in 2016. So huge transitions underway in the world around us due to both the epidemiological and demographic transitions. When we shift to risk factors, the leading risk factor, now that we quantify preterm birth and small for gestational age, combined with child malnutrition and maternal malnutrition, those all together is the number 1 risk still. But diet is number 2, diet quality, not quantity, because in the tradition of diet epidemiology, we distinguish quantity from quality. And then we have high blood pressure, tobacco, air pollution, and high fasting plasma glucose as the top causes. One of the things that's missing on this graph, and for reasons of time I didn't include, is the trend in these risk factors. And amongst the leading risk factors, the one that's actually increasing substantially over time, the only one, is high body mass index. So we have amongst the leading risks in the world one that really stands out as quite unique, namely very large increases globally in overweight and obesity, and it is one of the leading risk factors that we observe. And just to make the point on obesity, there is not one country in the world in the last 25 years with a statistically significant decline in overweight and obesity. So 0 success stories at the population level, even though there's some small-scale community-level success stories. As Alan mentioned, here's in English, the GBD Compare is there for you to explore the database. There are 4 billion results from the GBD in the current cycle that you can instantaneously explore in a wide array of visual tools that is widely used for teaching, but also for many other purposes out there. And we really encourage people to dig into the data, use it, and also critique it as we go along. Now, what I'd like to do in the last section of this joint presentation is talk about some of the new directions that we're very excited about on the GBD. You can imagine leading a collaboration of 3,500 people. There's lots of new ideas every cycle and lots of directions that people are taking the work. And I'll just give you a few. We're very excited that in GBD 2017, for the first time, we have undertaken our own systematic analysis of population. We've had this internal inconsistency that's bothered us for years in the GBD, which is we've been using the UN Population Division's numbers for population denominators. But in places where there are not regular censuses, population numbers are themselves a function of estimates of fertility and mortality and migration. And the UN has different mortality numbers than we do. And so we've basically had an inconsistency, a logical inconsistency there. And so we've gone back and done what I think of now as the sort of standard GBD type analysis, which is find all the data and then develop a statistical framework to estimate and fill in what we're missing. And so we've been able to identify 1,257 censuses. There's another 55 or so that we know occurred or we think occurred, but there's no published tabulation for over the last 70 years. And then we use population registry data, and that's for 26 countries. We do the things you would expect. We correct for age heaping and under-enumeration, and then we've built, building on work from others, from Agent Raftery and colleagues, we've built a Bayesian model to estimate population by age, by sex, by cohort, using the available data and using the GBD estimates of mortality and fertility. And then we have also taken into account where data are available, which is much more sparse, migration data. And I'll just give you one example of the findings from that, which is here's population growth in the period 2010 to 2017. All the places in orange and yellow, population is declining, including Michigan, as you can see on that. And if you go one step further and ask not about population growth, but where are you on the fertility transformation, we've reached the point in the world where half the countries in the world are below replacement fertility. So it's a real watershed. And you'll see in a moment on our forecasting work, we expect the world as a whole to hit below replacement fertility within about the next 15 years, 15 to 16 years. Now, there's a gap between below replacement fertility and populations declining, and that gap's about a generation. Slightly depends on where and what. But we've already reached the point where for most governments, the issue is not population growth, it's the threat of population decline. Now, we published last week something that's been a long time coming, and that is our foray into what we think of as a modern forecasting modeling framework for the GBD. Alan and I published in 1997 the first GBD forecasts. Then there was another round using the same model that we had developed, published by Colin Mathers in the mid-2000s, so around 2004. And there haven't been any comprehensive forecasts since. And we published last week forecasts for each country a reference scenario, a better scenario, and a worse scenario. Better and worse being defined by the observed rates of change in the independent drivers. So better is the 85th percentile of rates of change for each of the independent drivers in the past, thrown into the future, and worse is the 15th percentile. This model straddles two worlds, which is why this took a long time to do. The world of econometric forecasts or demographic forecasts, where you care strictly about out-of-time forecast performance. You hold out the last 10, 15 years of data, you run your model, you predict and compare to what actually happened, and you pick the model that predicts the best. And in general, those models tend to be just autocorrelation models, or REMA-type models. On the flip side, people want to ask questions about the future. They want alternative scenarios. What would happen to the future if I do a better job with water and sanitation, or faster scale up of PCV for children? Many scenarios that people want to know about. And we've been able to straddle both worlds. We've created a causal model that has as good as or better forecast performance as the existing models out there in the demographic literature. And that's what came out last week. And I'll just give you one flavor of those results. There's tremendous detail because we're forecasting the entire GBD into the future. And the difference about the future, there's one past, there are many futures. And so it actually generates far more data than the GBD does, or at least data that you can explore. So this one slide on the forecast, on the top right panel is fertility, and that's the blue line is our reference forecast, and you can see that we drop below replacement, 2.05 for the TFR, around about 2035. And then you see a wide range between better and worse for fertility trajectories. The second panel on the top right is life expectancy. We predict a slower progress globally, the blue line, in life expectancy in the next generation than in the past generation. A lot of that is obesity, but not only obesity, but that's a very key part of the slowdown. And the range between better and worse on this is 8 years in 2040. Which is huge. So within the credible observed rates of change of the key drivers in the past, if we roll those into the future, there's potentially 8 years variation, or potentially more difference between what we do now can have a profound effect on the future. And then on the left side here is the age structure of population. And what's interesting, and that's lost in when people disconnect fertility from mortality, which we don't in this model, because the same independent drivers that are driving mortality are also driving fertility, is in the better world, we actually see faster declines of fertility, meaning you get the green line, you have fewer kids in the future, or children, but you also have more older individuals because mortality is lower. And so there's not that much variation, as you can see in the bottom right panel, in the difference in population, at least out to 2040, between better and worse. Huge variation if you're interested by 2100, different topic. And we believe the UN has hugely exaggerated what the Earth's population will be by 2100. Cause structure will continue to change. These are ternary plots, and which shows you that the transition in the world from at the communicable maternal neonatal injury at NCD, the dots moving from the past and into the future towards the vertex at the top is towards a profile of burden dominated by non-communicable causes. And what's perhaps most important here is in the bottom right for sub-Saharan Africa. Even in the reference scenario, we expect that by 2040, still half the burden will be communicable maternal and neonatal causes. So the epi-transition is not going to be that far along on current trajectory in sub-Saharan Africa, even though it'll be very far along everywhere else. Look at South Asia on the bottom left, where we will be quite far along in the epi-transition, we expect, on current trends in South Asia. Two last slides, or actually one last slide here on some other directions for the GBD. We've been asked increasingly by the users of the GBD to tell the users about the strength of evidence for the risk factor work. We probably have more confidence in the relationship between tobacco and lung cancer than we do for processed meat and ischemic heart disease, as an example. given the number of cohort studies, given the strength of evidence that's out there. And we've been using subjective criteria in the GBD that are established by the World Cancer Research Agency, called convincing or probable evidence. But you can't write a computational algorithm that will return whether that evidence is convincing or probable, because there's still a very strong judgmental component. And our target right now is to be able to precisely define strength of evidence in a way that we could have a computer tell us. And that turns out to be quite a task. There's the GBD process for the risk factors uses nearly 2,500 cohorts and trials and a smattering of case control studies for rare events. And we are trying right now and expect to deploy for GBD 2019 this star rating system for the strength of evidence. We are adding antimicrobial resistance to the GBD. This is a project that was initiated by Sally Davies in the UK government, and then with support from Wellcome and the Bill and Melinda Gates Foundation. And we will be first publishing on the burden of sepsis. That'll happen early next year. Then the burden of all the pathogens behind sepsis, and then finally the burden of antimicrobial resistance. And then for the statisticians in the audience, we have had a long-running research project to convert our workhorse Bayesian estimation tool for disease incidence and prevalence that simultaneously estimates incidence, prevalence, remission, and death, to be able to fully have random effects in that over space and time. And that, age and time, and that will hopefully be deployed next year. The model exists, it's just writing the software. And it's the joke that we have in the GBD is that a big part of what we do these days is really running a software company as well as doing science, because a lot of this, having such a broad collaboration with so much data to process, you need to have professional grade software to support that work. So a flavor of the things that we're doing in the GBD. Sorry that I think I was on time. Alan was the one that ran late, but that's typical. And so thanks for your attention.
So as you were preparing your question, I thought I might be able to start with a question. You talked about the burden of antimicrobial resistance as something you're going to be doing. I'm sure you've thought about, and one of the things that in Canada we think about a lot is the burden of of climate change, both directly and indirectly affecting the burden estimates. And I actually thought you might mention something, but given that you didn't, that would be my question for you.
Should I do that one?
Yeah.
So yes, this is the question we get on the forecasts. So if you read the discussion in the forecast paper, we have a long-winded, hand-wringing that we haven't included climate yet. We've actually done a lot of work on climate so far. So the way the forecasts work is that all the risk factors in the GBD are the independent variables in the forecast platform. So the first thing we have to do is get climate into the GBD risk factors. And we've been working on that for a while, and the first thing that we're tackling is temperature, right? So we've put in as a risk factor temperature, and we intended to include that in GBD 2017, except that we ran across a problem, which is when you analyze all the data on temperature, it turns out that both heat and cold are very bad for you, but cold is worse. And so we sort of ran into an issue, which is that when we systematized all the evidence that's out there, at the global level, there's 5 times more harm from cold than there is from heat. That's currently, not in the future. And so we thought, well, we better really spend time and dig into that very deeply, and that's what we're doing before we publish that. We didn't want a presidential tweet on this cycle of GBD. And, I think what it's looking like is that finding's pretty robust. You talk to the people who work on climate, they sort of quietly say, yeah, that's true. Canada's going to really benefit from global warming in terms of, reduced cardiovascular disease, as will Russia. The issue there for including it in the forecasts is really around the potentially larger but much more uncertain pathway, which is rising temperature reducing rural agricultural yields in climate-sensitive environments, particularly in sub-Saharan Africa, increased rural poverty, worse health through that pathway, and potentially even conflict due to water shortages and food shortages. Super hard to model. And so we're scratching our heads on that one because you can just imagine how if you only model the part we know, which is the temperature part, and run that into the forecast, we could do a disservice by not characterizing the other pathways.
Do you think your characterization, which is pretty complex, would have an effect on the political attitude toward climate change?
No, on the presidential tweet, I'm not joking. I think we would get a "I told you so" exclamation point. So, of course, science shouldn't be driven by tweets. So, we will publish it eventually, whatever the evidence is. It's just we would like to make sure that we capture all of the pathways. And of course, there's the extreme weather event pathways as well. The interesting thing about that, the numbers on that, even in the other people's modeling, are comparatively small. They're like, 500,000 deaths a year in 2050 from extreme weather events, very bad. But in the grand scheme of, 70 million deaths a year in 2050, a relatively small percentage.
Carly, I see that your red light is flashing.
It's blinking. My question was actually building off of where you just were headed there was, I think what probably started as something that you wanted to be very kind of quantitative and non-judgmental, how much the judgment comes into this. And I'm just curious how you manage that responsibility.
That's why we have a lot of oversight.
Yeah, that's right. And I think behind Chris's response there on climate change was inherent this platform of oversight and criteria. We are very careful in the risk factors about evaluating science, and we don't make too much in the way of judgment. We're far more interested in trying to make sure we understand the science, and where the science is telling us stories that are different to conventional wisdom, then we look at it even harder. And so there are risk factor communities out there who say, well, why haven't you done this risk factor or that risk factor? And they're legitimate questions, but we just feel that the quality of the science is not at the level where we can confidently include it in things like tobacco or alcohol, blood pressure, where the science is much stronger. And you can also appreciate that there are industries out there who would like very much for us to say less harmful things about the risk factors that they cause. So I don't know whether you want to add to that.
I think the way we think about it is that we run a rules-based collaboration. So whenever we come up against big debates, we try to strictly apply the rules, and then if that debate leads us to want to revise the rules, the evidence rules, then we're open to that. And we have Peter Piot chairs our oversight group, and they meet every 6 months to sort of breathe over our necks and make sure that we don't stray from the path of being strictly rules-based. So, I think it's very interesting because you do end up, the edge cases lead you sometimes to think about the rules.
So 2 quick questions, Chris and Alan. One pertains to how is GBD handling conflict and war and its impact on mortality? You may have seen some of the recent work which looks at this in the context of available DHS data. But secondly, how are you forecasting some of the issues related to conflict and insecurity?
Great question. So on conflict and war, the problem with conflict and war, as you well know, is the very data systems that we tend to depend on, for example, for cause of death registration, stop working in most conflict settings. So the people who study conflict, for example, Uppsala, one of the more well-known groups that study conflict, and we do the same and use very much what they've produced and others, end up for battle deaths depending largely on media reports, because you can't trust the reports from the combatants. And so the criteria for monitoring battle deaths is they must be very specific reports, either from NGO monitoring groups or the media, about who, where, and when. And if you don't have that precision, then we end up not using it. And, of course, there's, the Iraq debates were very intense and spilled into the scientific literature. Very imperfect, but there's really nothing else that anybody's come up with on at the time. And then retrospectively, you can get things from birth histories or sibling histories. You can get, the sort of surveys that have been done in DRC or South Sudan using, from refugee camp surveys. Very, very tricky to analyze for other reasons because of selection bias, but that's the main vehicle. We also do get a number of groups that work delivering care, let's say in Syria, sharing data from these NGOs that are at least observing injuries and other things that are related to conflict. For the forecasting, these are we model them as stochastic events that are correlated in space and time. And so it's a sort of autocorrelated stochastic process that we use, not great. But there are very poor predictors of conflict, as you can imagine.
So Sue Greco from Public Health Ontario, great talk. We're very familiar with your work as we're developing environmental burden of disease estimates for the province. I wonder if you can embellish a little bit on what you or Alan alluded to in your talk on the more geographically resolved burden of disease estimates.
So we have two themes on geographically resolved. One is a number of countries have worked with us as part of the collaboration to do first administrative level breakdown. It's about 16, 17 countries. And I believe tomorrow the UK will publish second administrative level burden of disease, as part of the GBD collaboration with Public Health England for England. So 150 local authorities for England. So that's probably the most, and that's the full GBD risk factors diseases at the local authority level. And that was really driven by demand from, the local councils who wanted that sort of information. The other stream of work is the geospatial analysis, where it's sort of parallel to the GBD and linked using some of the same data, using analyzing data at the latitude and longitude level. And so we've published in Nature this year, for example, for Sub-Saharan Africa, the geospatial analysis of child growth failure, education, and child mortality, which was actually Lancet, and a stream of those sort of analyses covering the low and middle income world coming out next year. Those are much more ambitious models because you're essentially trying to estimate at the pixel level with very sparse data. And so it's much more essentially model dependent, but they seem to give us useful findings, and some for things where environmental determinants are predominant, like vector-borne diseases, they work rather well. So that's sort of the two streams of work on the spatially resolved.
And just to add a quick comment, most of that work is driven by country interests. So China, India, Indonesia, they wanted to have GBD at finer resolution. So we're often, what we'd like to do, obviously, see more of that. But it's really where countries have picked up on this and said, no, we need to see it at a finer level.